Hello. Hello. So, hello everyone. Welcome to HIPCON 2026. I wholeheartedly welcome you all in this chilly weather that you have taken your precious time and come to the conference. So, this is a conference that we are doing on revision hip surgeries and complex primary THRs. I think this will be the first of many that we'll do in future. We have excellent faculty list right from outside Bihar to also Patna and Bihar, and we'll cover the most part of the complex primary sessions today and most part of the revision surgeries tomorrow. So first I would invite Akshat to kindly coordinate the sessions. Akshat.
Welcome my seniors, colleagues, all the delegates and faculties to HIPCON. Thank you, sir, for giving me this opportunity. So time is of essence, and given that you have all come and you are spending your valuable weekend with us, we'll make it more memorable and a time well worth spent. For the first session, I'd like to call the chairpersons, Dr. Vikram Veer, sir, Dr. Saurabh Chaudhary, sir, Dr. Shamir Rahman, sir, and Dr. Sujit Tripathi, sir. Should we start, sir? Should we start? Yeah. I'd like to call the first speaker, Dr. Janki Sharan Bhandani, sir, for the topic on lessons from periprosthetic femoral fractures.
So, welcome all. And so, I am talking about the periprosthetic femoral fracture. So, what we can learn from it, the learning objective is to know about the classification, the old one what we are using and its extension, and to know how to assess stability and how we can misclassify it, how we can lose stem, and to know when to fix and when to revise. So the incidence of periprosthetic is increasing because of more number of aged population and more number of hip arthroplasty in recent years. So because the fracture what we usually have without a prosthesis inside is simpler than this, so there are high complication and failures when you treat these, and you should follow the principles like you should assess the stability before decide the management, and to know the fracture pattern is if you compare it with the stability, it is less important. So coming to the classification, what we were aware of is about the Vancouver classification about type A, B and C, which is similar here. A is apophyseal, means like greater trochanter and lesser trochanter fracture, and type B is when it involves the bed of implant. So that is type B, and type C is when it is clear of implant. And in unified classification system, that Vancouver system is extended, and it is actually not for the treatment purpose but for simplification to communicate. Like type D is dividing implant, that is interprosthetic fracture. Like if you have TKR and THR, the fracture in between, you can call it type D. Type E, when you have a THR and you have both acetabular as well as femoral side of fracture. Type F, like when you have a bipolar implant and you have acetabular side of fracture. So for simplification purpose, the type A, B and C is like Vancouver, and like in type A you have GT fracture. Type B is again subclassified to know it is stable or not. the quality of bone based on that. If it is a well fixed implant, then you can call it as type B1. Type B2 is when you have a loose implant. And when it is the bone quality of bone is poor with loose implant, you can classify it as type B3. And type C when it clears the implant. So the loosening is actually you should take care of type B fracture, because in type A when there is just apophysis, or type C when it is clear the implant, then there is no chance of loosening usually. Like in this case, which is the patient having a bipolar prosthesis before, and it appears a well fixed stem. We have assessed there was no pain before the fracture, and the fracture, when we see there is no subsidence on X-ray, and there is no major osteolysis. So even in intra-op you have to assess again, because about 20% of the patient, when it looks like a stable fracture, when you open it, usually it is loose. So that intraoperative assessment is also quite important. This was well fixed intraoperatively, and it was fixed, and this was the result was quite good. And this is another case. The initially patient presented with intertrochanteric fracture elsewhere, where it was treated with a bipolar prosthesis with GT, the TBW of greater trochanter, and it fails. Later it actually fractured, and the bone quality was not good. There is subsidence and osteolysis you can also see. So this was the thing which was done with the longer prosthesis. Usually when you use a prosthesis, it should extend at least 2 cortical diameter to the normal bone from the fracture site, and with surplus wire was applied, and this was the result. This is another case. It was a failed implant with avian of hip. So initially the patient has intertrochanteric fracture where the TSP and DHS was done, and there was avian of the head, which later with a bipolar prosthesis was managed, but there was subsidence and osteolysis, and the when presented to us, this was the situation, and because the bone quality was good and prosthesis was well fitted, so it was decided that we should fix it, and a longer implant was applied. So implant usually is stable, and the bridge over comminution should be done, and should avoid a stress riser. We should apply a longer plate. This is a type D fracture when you have both side of prosthesis, and for that one it was like when the fracture is like this type, if some fracture like which prosthesis is more affected, you can classify it according to Vancouver to that, because type D will not determine your treatment, but you think of one side, like here it's usually more towards TKR, so should be taken into consideration while fixing it. There are many new plates which help you to fix it better. Type E is when you have a fracture which is either side of the prosthesis is fractured, like here acetabular as well as the femoral side. So you need to do a block out analysis, like for the femur you should see, like here it is a type B3, and for the acetabular side as well, if you see there is loosening and bone quality is not good. So you should assess in that way, and then you manage. So like here, bipolar was there and there is acetabular side of fracture. So you should also look for a stability of adjacent implant other than displacement and combination to manage this. Like in this case, it was stable and not much displaced, so conservatively it was managed. So the common pitfall what we used to have is like a type B1 we can, which may be a B2 type, like the loosening is not always able, we cannot assess it as always, like even if you have a CT scan, so intraoperative assessment is also quite important, and ignore pre-fracture pain, which you should not do, and the fixation length should be adequate, and over-reliance of plate without addressing stem stability is one of the things which should be considered whenever you are managing such cases. So there are some classification pitfall, like if there is a fracture of prosthesis, it should not be classified as a periprosthetic fracture. You should call it as a mechanical failure. And like this case, though in intraoperatively it was found that there was fracture and it was managed accordingly. So decision making, you have some gray zones like borderline stability. Whenever you have, you should be more careful, and when to apply surclage, you should note it down, because the surclage is having a stability which is about 1/4 of a screw, and whenever there is a quality of bone is not good, like B3, you may need a strut graft, and timing of management is also important, and you should also assess weight bearing protocol according to the fixation, though early weight bearing always have a better result. So apply both arthroplasty and trauma principles, and well fixed stem and a good bone stock always you can fix it. But if there is a there is a loose stem, it needs revision, and not all simple fracture is B1. That should be kept in the mind. And when you have a poor bone stock, the strut graft improves biology as well as load shielding. Thank you.
Very nicely explained. Any questions from the audience? Okay, we'll have the discussions at the end then. We'll invite the next speaker, Dr. Vinod Kumar Thakur sir, for his talk on stage salvage of infected acetabular fracture from girdle stone arthroplasty to cup cage reconstruction.
So, good afternoon. Thank you in organizing committee. I am to be part of the here. I am before you. Thank you. I have come here with one of our interested case, which was treated at my center. With a 48-year-old gentleman, IT professional, history of RTA on 20th/11/23. He was treated elsewhere with acetabular, he had acetabular fracture and it was displaced. I think it was the posterior wall and posterior pillar, everything was there, and hip was also subluxed. So he was operated elsewhere, and he presented to us after 3 months. And when we came at our center, he had intense pain in the right hip, he was unable to stand. He had discharge of plus and as well as the foot drop also. He had all the problems and very pitiable condition. He came to us. His X-ray and CT, it is not of good quality, I think so. And I do not have the pre-op X-ray. Just after the injury, he didn't have. These are the CT. But after 3 months, when he came to us, we decided to operate him, and the Mata plate was removed, the massive wound debridement was done, the joint was dislocated, and all the corners of the hip was seen. It was thoroughly cleaned everywhere, cultured, biopsy, everything was taken. But only thing, we did not remove the femoral head. In the interest of the, we preserve it, the make use of bone grafting in the, during the THR procedure. So wound, as usual, healed in the due course. After surgery, he was put on traction, and in due course, 2 weeks, wound healed. He came up for checkup after 2 months, ESR, CRP. I do not have the report, but it, as far I remember, it was settling. And after 3 months, he was planned for the replacement surgery that was planned for the cup cage reconstruction along with the bone grafting. He was planned like that. And as he was operated, again we found infection inside. We found infection inside. So we planned, we changed the plan, and this time radical debridement was again done, and excision of the head was done, and the cement block was put, a spacer was put in the posterior superior portion of the acetabulum as well as in the stem, and the head was made with the bent K nail, and again the wound was closed, and wound healed in due course. The pain which he had earlier, it's subsided to some extent, and after he came for checkup, and after 5 months of this surgery, again he was planned for the revision arthroplasty, and again cup cage construction and the bone grafting he was planned for like that. And he was operated. This is the operative x-rays. This is the bone cement which was taken out, the spacer as well as from the both side, stem side and the acetabular side was taken out. The bone grafting from the same allium was taken, and it was put, the cage was put and fixed with screws, and finally the cup was put with the help of bone cement, and the stem was put uncemented, so reverse arthroplasty was done, and this is the x-ray. The pelvis is tilted. It looks somewhat vertical, but pelvis is tilted like such a way, and reverse hybrid replacement was done. It was the 22nd of the December 24. So after 6 weeks he came to us. The hip found stable and the graft was incorporated, but only thing, after this surgery we advised him to have rest for at least for a month, and after that he started ambulation with the help of walker, and he came after 6 weeks. The x-ray was found satisfactory, and again after 6 weeks we advised him to walk with the single stick, and this was the March of the 25th. He came for the checkup. The hip was stable. He started ambulation without any help, but had some lurch, and he went back to his work. And again in the last this December he sent me the x-ray. This x-ray, I think more or less this is looks to me okay, and this video, I think anyone will help me to run it. So a few days back he sent me the video and the x-ray. So my take home message is, Infected acetabular fracture are best treated with stage salvage strategy. Infection control is the first priority, often requiring girdle stone arthroplasty. Definitive reconstruction should be delayed until infection is completely eradicated. Cup cage reconstruction allows stable fixation despite bone loss and prior hip surgeries. Careful staging can restore function even after multiple failed procedure. Thank you.
Thank you, sir. So we'll take the question at the end because the discussion is there. So the next speaker is Dr. Sudeep Kumar.
So I was thinking of using sir's 2 minute which was left. Huh? Right. Okay. Right. Okay. So kind of good afternoon, everyone. Good evening. Sorry. So and welcome to this HIPCON 2026. So my task is to tell you about top 10 or 5 causes of revisions or failure of a total hip arthroplasty and early arthroplasty. So probably we all know that it's very devastating, and acute results probably more or less gives you a long-term outcome. If acute results are not very good, they are not, your hip is not going to last for the time it is supposed to last, for 15 years, 20 years, for whatever time you want the hip to last. Okay, and for all total hip and total knee, most of the failures can come very early and then gradually over after 2 years' time. Probably the failure rates will go down as you are becoming more accomplished surgeon. So early failure accounts for around, so if you consider all the failures, the early ones will account for 25 to 30% of all the revision procedures that are performed worldwide. And it represents a significant data, and this is a data from United States, and I'm sure that it will not be untrue for our Indian scenario as well. So there have been a lot of papers about what leads to early failure. Okay, there is an Indian paper, there are a lot of Western papers as well, and if you see the Indian paper, it is mostly infection that is the most common cause. Though in UK and Australian and Swedish joint registry, dislocation have now taken over. If you see the registries before 2010 data, they were different, but now 2010 to 2025 data, dislocation is the most prominent cause in the Western joint registries, but in India, probably infection is still the most common cause of early failures of your total hip arthroplasty. And this is NJR 2025. 3 to 5% they have an early failure rate, and it is a huge cost to the patient, to the system, to everything else. And here also the most common cause has been dislocation. So there are a lot of literature about causes of failure. If you see immediate intraoperative complication where you know that you have done something wrong, it's going to fail, probably would be a major bleeding or an intraoperative fracture if you recognize it. So that can cause one. Early postoperative, which may be up to 3 months. So these are what? Dislocations, infection which can come after the patient you have discharged the patient, you have removed the sutures, the patient can come in 15 days, 20 days with a leaking wound. So that is second. And which is not very common, but then we see one of, maybe some of you may have more experience there, metal allergy, though just a more or less theoretical. Midterm failure would be, again infection will be one of the important cause, 3 months to 1 year. Painful hip, maybe because of iliopsoas impingement, or maybe because of the malposition of the joint. But the long-term failures will be like 2 years to 1 year to 3 years will be aseptic loosening. Again, infection is always there, and liner wear. You have a polyliner. I need not say we are using all sorts of companies now, and we don't know how the liner behaves in longer term. When you revise other cases or other surgeries, you know how the liner is behaving 5 years down the line. So we are seeing this liner wear and liner failure more often than not nowadays. So be very cautious. So again, as said, 0 to 3 months. Dislocation is the most common cause, but dislocation will happen in the first 6 weeks. So that is also important to know. Infection would be wound issues, fever, discharge. Patient will present to you with some constitutional symptom. You can't keep on suppressing it with antibiotic. And periprosthetic fracture. 80% of them are intraoperative, which you fail to recognize, and whatever you see in your follow-up probably are the ones that you have failed to recognize, and they show up in the first 4 to 6 weeks. In 3 to 12 months, again, low-grade infections, in our scenario, more so important because we keep on adding antibiotics without investigating, without going into the cause. Early aseptic loosening because of component malposition, poor implant positioning, poor quality, poor component sizing. And nowadays it is more, it's kind of, we are doing uncemented hip for also. In a wider canal, we are doing an uncemented stem, and that is again a cause of failure. It can lead to an early failure. Leg length discrepancy I have written here, though patients don't mostly report that, but then that's also a cause of failure if it is too much leg length discrepancy. And abductor insufficiency. So we keep on rehabilitating our patient while we haven't addressed the abductor problems that we have had, which I think few speakers will speak about protusio hips, about fixed hips where and abductors, and I think Sujit has a talk tomorrow about abductor deficiency, how it handles it. So this is one which we don't address more often, but then patient does present with abductor deficiency or lurch as well, in spite of all the good surgeries. So 1 year to 2 year, again aseptic loosening, adverse tissue reaction. These were, I have two recently had got ceramic failed, ceramic liner broke, patient had a trauma done in 2016, one was done in 17. Patient didn't come for follow-up, asked to remove, and it was a huge blackening inside. I just could not be salvaged. Everything was destroyed. So this ceramic also causes lot of reaction, and of course the ceramic head rubbing against the metal cup which is left leads to lot of problems. So bearing surface failure, heterotrophic ossification, these are some of the causes. But then those who have done lot of ceramics in the past, if the patient is having a fracture, immediately needs a treatment. Otherwise, it will end up patient, because patient is not very painful. Unless until there is a huge problem, patient will keep on walking. So that is one problem I've seen, two last year only. So that is one to be seen, and both were done by us in 16 and 17, ceramic on ceramic hips. So according to the approach that we do, so posterior is the most common. I am a posterior surgeon for all my total. So dislocation is the most common cause. Component malposition is very, very important that you need to see. And proniosis, if at all it is there, you have to see. But then dislocation, most important, component malposition. These two things are surgeon control, easily can be managed, easily can be planned. Okay. Now, if you're doing anterolateral or Harding, abductor insufficiency is a very common problem. If you don't split from the gluteus medius abductor area from the rotator area. So you have to, and you don't repair it adequately. So this is very important. So limb becomes a problem, though there is a very less chance all across the literature about dislocation. So direct anterior approach is now many people are doing it, are utilizing it. So but then it has a huge learning curve, and you have to be very, very sure about what you're doing, where you are pushing your component, because changing from posterior to anterior, it can also be a problem. Okay, those first 50 cases where you land up in a problem are your numbers, but those are one-off cases for those particular patients. So you have to be very, very careful. Direct anterior, so femoral fracture, because delivering the femur becomes very, very difficult in the first few cases unless until you master this. Infection is very common, as I have said, but I'll say that again, India problem is that gram-negative polymicrobials. In Western world, it is mainly staph, okay? But in India, it is more gram-negative polymicrobial, our uncontrolled diabetes. We haven't checked them properly. We have nutritional status is very poor. Patient just come for surgery and leaves. So there probably is not our strategy in India. We have to do a two-stage. But of course, if you are very confident about your bug, what are you going to isolate? If it's one-off cases in your setup, if everything is under control, then there is what you can actually plan if you isolate it early. But you have to be very, very careful in your scenario. Again, coming back to DAA, so you're crossing the groin crease. Okay, you have to be very, very careful because the wound infections are very, very common. And these are some of the very well-accomplished surgeons' paper. This is not mine. Okay, so they had a complication rate up to 1.4 to 2%. They have 11% when they began in 2016. They published. They came to 1.9. Again, they republished their series in 2023. So it is a very big problem. They have found a strategy how to navigate. So those who are dwelling it, learning it, doing it, you have to be a bit more careful about in DAA because you are crossing the groin crease. Dislocation, again, you have to be very careful about your component. You can use some technology because newer people, you can use technology. It may require liner exchange, head upsizing, constraint liner, but then get it right the first time is the key for avoiding dislocations, instability. So I'll skip all these things because if your components are malpositioned, it can lead to long-term failure. Edge loading, your poly will wear, your ceramic can fracture, patient will never be happy, there will be SWAS impingement, okay? So I'll go through abductor mechanism problem I have already discussed. So these are protusia hips where you can't dislocate, you have to do an in situ osteotomy, and these are the patient where you can land up in a fracture as well. So you have to be very, very careful. Short, stocky, females, patient, you can land up, but of course patient, if you recognize it, you address it, they have a good long-term function. Protusio, I think Ramakant has a talk on that. You have to have a good bone graft, impact it, and again, I have designated this because you can have a fracture. I'll just skip periprosthetic fracture also is common. So a lot of patient-related fracture which can lead to failure, which you can't control, some you can control. You have to look into it. A neurological problem is one. I'll just go through not poor surgical technique. Limb discrepancy is coming up a big time. If you're doing both the sides, you have to manage the limb length, you have to counsel the patients properly. So yeah, we are not seeing this, but I saw this too last year only. So we have to be very meticulous in your planning. Appropriate implant selection is very important. And optimal, use your cement. Cement is your friend. Don't just rule out the cementation as of now. Learn cementing. If you're not, please learn cementing. Cementing is a very good technique. So these are some of the patients that looks like this, but you have to plan it accordingly. Spine, hip, spine, I think spinopelvic parameters are to be looked into. These are some of the patients. So yeah, you recognize them early, treat them early, make a protocol. Thank you so much. Sorry for exceeding the time.
Thank you, Sudeep. Any question from the audience? Yeah. To all three speakers, you can ask to all three speakers.
Hello. Yeah. So first question from Sudeep. So you mentioned the most common cause of the failure is dislocation, early failure, no?
Yeah, across the registry.
But you gave the reason that capsule repair and short rotator repairs is the major cause of the.
No, I didn't give any reason. I just.
But you wrote it why. Why means capsule.
Yeah, so dislocation.
So even in THR, most of the time you don't get the capsule because it is contracted. So I think most important
is the version, is your version and inclination is the most important. 80% of the time, the kind of patients that we get,
but
you won't be
above all, soft tissue balancing is most important, as important as
your
in
offset,
the knee.
Your offset, your length, limb length discrepancy management, and your acetabular version depending upon the approach.
If you can't dislocate easily on table after putting the implants, final implants, then it's not going to dislocate most of the time.
Probably yes.
Yes.
Probably yes, but
yes,
then you are always milder when you are testing on the table as well. So very careful.
I think if you have made your version,
inclination, correct, yeah.
offset including femoral and global, I think.
Yeah, the horizontal offset and the vertical offset is very important.
Globally, offset is very important.
An increased offset stem. We don't have differential offset stem in uncemented. At least in Patna, you don't get it. Okay, but then
it's very subjective, no? Offset and on table.
No, so there are technologies where you can actually manage. When you can do a pre-operative templating and you can plan well in advance. So it is not that it is rare. It can easily be done.
Yeah, you can do the pre-operative you can planning and you can do that. So component malpositioning is one of the main factor along with the soft tissue disruption both.
Yeah, soft tissue balancing is most important.
Yeah.
Even if everything is there. My question is to Dr. Thakur sir.
Just one comment.
Yes.
Dislocation is multifactorial. There are multiple articles that says that if your implant is in the right position, its version and inclination is correct, even it can dislocate, right? So there are multiple scenarios.
See, your testing
Just
is in
positioning
supine or
the
lateral, and patient is under anesthesia. But when the patient gets up, the muscle tone and everything comes back.
But
So what is playing? But then, of course, what is in your control is your version, inclination, implant position, horizontal offset, vertical offset.
You haven't attached the soft tissue yet, and still your implant are in a stable position. You can't dislocate it easily. Then it's okay, I think. Yeah.
And the problem is that you have taken a reference in the lying position lateral, and that may change, and that may create problem. So everything is not under your control.
Yeah.
Yeah. Any other question?
My question to Dr. Thakur sir is that in most of the post-operative X-ray you have shown, no? So right hip, that is the operated hip, is in the adducted position. So any reason for that?
So Rajiv, as a
Can you play back
as
that
I know,
X-ray?
as I know, the X-ray was not a square; it was tilted. Number one, the X-ray which was put here, it was tilted. It was
But
like
later X-rays, no, first was
like this
tilted,
way.
but
And
later X-rays all are in the pelvis square,
And
but limb is adducted.
And number one, after the surgery, in each and every cases, our habit is to see the abduction fully. If any doubt, we do not have any hesitation to do the adducted tenotomy. This problem, this patient is having so many operations and having foot drop, and these are the problems. He is having the lurch, he has not a square X-rays, so these are the things in between, I think so.
Yeah, maybe
But
compensatory.
he didn't have any abduction problem. The limb was quietly abducted after the surgery. No any tightness in the adductor side, nothing. Okay.
Sir, was it a cup case or cage cup? I think you have applied a cage and then the cemented cup.
This uncemented cup.
That is a cage and cup, not cup and cage.
Yeah.
Can you first sell, then cage, and then cemented?
Yeah. The graph first.
For discussion purpose, cup cages that means putting a trabecular cup over that, putting one cage.
Yeah, so uncemented cup, then the cage, I think they both are screwed in, and then cement, I think then cementing was done.